You ready, Grace?
Yes, I am.
Okay, so I'm just going to take this opportunity to introduce you. So I want to thank everybody for coming. This is the Illuminate Speaker Series for the College of Rehabilitation Sciences. And so we're very fortunate today to have our presenter, and I want to tell you a little bit about her. So Dr. Grace Vincent-Onabajo is a registered physiotherapist with the Medical Rehabilitation Therapist Board of Nigeria. She holds a PhD in neurological physiotherapy from the University of Ibadan, the premier university in Nigeria. And she was an associate professor teaching undergraduate and graduate courses for about a decade at the Department of Medical Rehabilitation in the Department of Physical Therapy in the University of Maiduguri, where she also served as the head of the department for several years. Dr. Vincent-Onabajo has supervised over 35 research dissertations. She has 42 publications in the field of neurological physiotherapy, and her research focuses on the analysis of stroke aftermath using the ICF Disability and Health Scale, especially post-stroke social participation and return to work and leisure, quality of life for stroke survivors and their caregivers, as well as physiotherapy education and training in Nigeria. Her current research interests include stroke rehabilitation and outcomes in women, especially those of childbearing age. Dr. Vincent-Onabajo serves as an external examiner for doctoral examinations and a reviewer for scholarly journal and WCPT congresses. So we'll let you take it from here, Grace. And just to let you know also that there's people listening to the presentation live. It's being streamed, so just to let you know that.
Thank you. Thank you, Dr. Barbara Shea. Thank you for the invite. Good afternoon, everyone. I'll be talking on the outcomes and competencies of pregnancy and puerperium rehabilitation related stroke rehabilitation. The core of this presentation is about the data. It is so obvious that there is a dearth of data regarding this very important aspect of stroke rehabilitation. And as we know, if any aspect of rehabilitation is not so well taken care of, then the clients and the patients, their caregivers, the family will be at the receiving end. So this presentation is to take a look at the available data regarding rehabilitation outcomes and competencies for women who suffer stroke during pregnancy or postpartum. So I'll go straight to the presentation. So a bit of a background here. Stroke in pregnancy and puerperium. It's rare, that's a known fact, but the incidence is on the rise, it's on the increase. And there's so many, there's a lot of literature regarding this particular condition in women. And regarding the incidence, the rise in incidence, we know that over the years, the incidence of stroke, the mortality from stroke, and also the functional outcomes from stroke has been a focus of several studies. But in women, the rise in incidence is particularly concerning. A study that was conducted at the United States some years back compared the incidence of stroke in pregnancy at two different time points, the mid-90s and in the mid-2000. And the increase was recorded, the increase in incidence was recorded to be 103%. That is a whooping increase, a whooping amount of increase in incidence. There are so many factors that could be responsible. Some of the authors believe that probably lifestyle factors, increase in pregnancy-related hypertensive disorders, and all of that could be responsible. But the actual cause for the rise, for the increase in incidence, cannot be ascertained at this time. It's also important to mention that stroke in pregnancy and puerperium is an important cause of maternal morbidity, mortality, and fetal. Of course, studies have shown that in many cases of stroke in pregnancy, the outcomes could be very dire depending on the type of stroke. Hemorrhagic stroke in particular has a record of high mortality rate. And then the management of this particular condition needs to be individualized, because as I go on in the presentation, I will show you how diverse the risk factors are, the causative factors are, the presentations are. So that would require individualized management, because it has to be tailored to the need of each patient. And as I said earlier, the devastating effect of stroke in pregnancy is profound on the mother, on the baby, on the family. Yes, stroke is a life-changing condition, but in pregnancy, it is much more, because pregnancy and motherhood on its own is life-changing. I mean, changes to the physiology, changes in the body, the excitement that comes with being pregnant and expecting a new member of a family and then when the baby comes, all of those are life-changing. But to now have a stroke in the mix can really be devastating. And there are several instances where people that have gone through this experience have told their stories, and those stories are quite touching, and one can just imagine how they feel, the family, the mother, the partner, and all those involved. So it is a very serious issue that needs to be tackled with all empathy and concern as rehabilitation professionals. And I would like to mention here, just for the sake of to define my terms, the puerperium is 6 weeks from the time of delivery of a baby, and then of course we know stroke as it affects the cerebral function, focal or global disturbance of cerebral function lasting more than 24 hours or leading to death. So it's important to put those in context. So the big picture, beyond the pregnant woman, stroke in women is an issue that deserves appropriate attention. I have some points here that really drives home the enormity of the problem in women. The Heart and Stroke Foundation of Canada puts it as the #1 cause of premature death in women in Canada. It's also the 3rd leading cause of death for women in the US. And beyond the high figures, the prevalence in women is higher than in men. And unfortunately, despite this burden of stroke in women, the emphasis in research, the emphasis in care has not been so much on the women. In fact, there are available data that show that there is an underrepresentation usually of women when it comes to clinical trials for stroke, when it comes to interventions that should assist access to healthcare. Like in my country, in Nigeria, access to healthcare for women, there's a bit of imbalance, there's a bit of inequality. And to look at the burden of stroke in women, one would have expected that the focus of all that is needed to restore function, to improve quality of life, would be targeted at this particular vulnerable group. But it's unfortunate to admit that that is not the case. Also, when it comes to outcomes, the aftermath of stroke, more women are disabled. There are so many studies that have proven that. And I'm going to show some of my own studies too, that even in my environment here, that attest to the fact that women are at a disadvantage when it comes to the stroke aftermath. And lastly, it is quite disheartening to note that with the burden of stroke in women, the first ever prevention guideline for stroke that was dedicated solely for the women was published only in 2014. So all of these years, there was nothing to fall back on except to obtain some information from general guidelines. And as I said, because of the underrepresentation of women in clinical trials for stroke, then the major issues that concern women were not really elucidated in those guidelines. But thankfully, it's better late than never. Now we have a guideline, though for prevention, for stroke in women generally. So this is one of my studies. This was one of the publications from my doctoral research. And we looked at gender differences in longitudinal patterns of functioning among Nigerian stroke survivors. The study itself was a longitudinal study, a 12-month longitudinal study to look at motor performance, activity, participation, and quality of life post-stroke over a period of 12 months. Pardon me. But part of the data extracted, we now decided to look at the pattern, comparing it between male and female because of what we have observed to be the situation in clinical practice, in research, where women are underserved and underrepresented. So we looked at this as like a secondary analysis of the data obtained. And from this chart, you can see this motor performance was assessed with the Fugl-Meyer scale, and higher score depicts better function, better motor performance. So from the 1st to the 12th month, yes, there's improvement in the among the female stroke survivors, but you can see that from the outset, from the baseline, the motor performance of the male was much better, and their improvement. Yes, the women improved, but they did not catch up, at least based on the scores presented. In this study, we didn't find a significant difference in terms of the p-value, and that was due to a limitation we observed. The sample size didn't power that, but the scores, merely looking at this chart, shows that the difference, the motor performance in women cannot be compared from baseline to the end. Also, we looked at activity. We measured that with the functional independence measure. This is a bit close, but there are many reasons for that. Probably some of the chores that the men engage in, like more of the activities of daily living. Of course, there can be compensation, and it doesn't really reflect actual recovery. Not all the time, actual recovery of motor function. It could be by compensation, but there's still a bit of difference in the pattern across the years. A recent study that we did, that was published in the Journal of Stroke and Cerebrovascular Disease in 2018, we also looked at balance function, and compared male-female, and that study there was a significant difference in the balance function or balance recovery of males. They did better, and the odds ratio was about 1.6, which is the male stroke survivors have at least over one time they are more able to recover their balance function than the female. So this is just the big picture, male female, but the topic is on pregnancy, and I'm back on that regarding what we know, because this topic is solely looking at the dearth in data, and the dearth is appreciable more in rehabilitation, for rehabilitation as a field, as a specialty in stroke care. So, but before we go into where or what is missing in data, in literature, I just put this up to let us know what is known. Several studies have been conducted to let us know the risk factors for pregnancy-related stroke. And we have some pregnancy-related factors and the traditional risk factors. Of course, the traditional risk factors, pregnant or not, this could result in this puts an individual at risk of stroke. But the pregnancy-related factors are specific. They are specific. They occur. They are complications, as it were, complications of pregnancy. So this is known. Also, theological factors. Several studies, review studies, systematic reviews, just plain literature reviews, retrospective studies, case series, prospective studies. A number of studies have been done to actually see which factors are responsible, which factors lead to or cause pregnancy-related stroke or puerperium-related stroke, and we have several of them that have been established in literature. Knowing that the childbearing age, a woman in her childbearing age can be considered as a young adult, and many of these factors, some of these factors, these etiological factors, have also been found to be common in young adults, except for those that are actually related to pregnancy, like the amniotic fluid embolism, the postpartum cerebral angiopathy. Those are unique for pregnancy. But ruptured aneurysm, arteriovenous malformation, these are not so, they are not pregnancy specific. They can result in stroke in non-pregnant people. So, the incidence is also known. As I said earlier, stroke in pregnancy is regarded as a rare condition, but as I said, the incidence is increasing and there is data to show. So I have country by country data regarding the incidence. We have in Canada, in Japan. Some of these studies are nationwide studies. The Canada study was a unicenter study, was just done at a center. The Japan study was a nationwide study. The USA study was a nationwide study. The UK study was nationwide, while the France study it was a multi-center study. But in all, we can see differences in the pattern, and some of these different in the pattern of incidence could be due to the study design, could be due to some factors in some population. I am not happy I can't present the incidence rate for my country here, but unfortunately we don't have data to that effect. But what is known here in Nigeria is that we have a high incidence rate of maternal mortality. It's quite alarming, and the government is actually working on how to address many of these causative factors. A recent systematic review was done by Rick Swartz. I think he's of the University of Toronto, I'm not sure, but I know he's in Canada. That's the latest systematic review and meta-analysis. And that was a very elaborate study, and they found that 30 in 100,000 pregnancies, 30 cases of stroke-related pregnancy stroke in pregnancy occurred in 30 out of 100,000 pregnancy. And I dare say even one is quite significant. So the numbers are not good enough reasons for why we have limited data when it comes to rehabilitation of this very important population. We also know about acute management. I'll be showing you a recent practice guideline or consensus statement that came out of Canada too regarding acute management. A lot of work is being done in Canada regarding this pregnancy related stroke, and it's quite heartening to know that attention is being focused on it, at least in recent times. This consensus statement I mentioned about acute management was published, I think, last year in the International Journal of Stroke. So one is heartened, one is excited to know that gradually, slowly but surely, enough interest is being generated, and enough work is being done a lot of work rather is being done regarding this topic. Secondary prevention, there's also a statement, a consensus statement, also from Canada regarding secondary prevention. Of course, where we come in as physiotherapists will be in the lifestyle intervention, weight control, regular exercise. Women's health physiotherapy specialists would be able to do a lot of that. Of course, they are always involved when necessary in postpartum, antenatal care of pregnant women. So the weight control aspect and the regular exercise is well within their purview. But generally, for stroke in pregnancy, one important outcome that should be prevented is recurrence, stroke recurrence, secondary prevention of stroke. And so we know now from available data that there are pharmacologic interventions that are used, also lifestyle interventions, similar to what is advised for anybody that has suffered a stroke. Stop alcohol, stop smoking, exercise, control your weight, check your BMI, eat well, good balanced diet, and all of that. So, as I mentioned, there are practice guidelines. The Canadian Stroke Best Practice Statement for acute stroke management, Best Practice Statement for secondary stroke prevention, and then the guideline I mentioned earlier, the 2014 guideline, that is generic. It's for women generally, but a good portion of that guideline was dedicated to pregnancy. So we have these guidelines, but looking at this slide, you can see there's a major thing missing, and that is rehabilitation. There is no guideline, there is no consensus statement for rehabilitation of pregnancy-related stroke survivors. So we have the first part, the hyperacute care, the acute care, and all of that. Secondary prevention, that's of course post-recovery and all. But what should be between the acute care and secondary stroke prevention, which ideally should be rehabilitation and all? WHITHER the data, where is it? It appears not to be available. Also, what is known? We know about the mortality that occurs. The pattern differs depending on the type of stroke: ischemic, hemorrhagic, cerebral venous thrombosis. The mortality rate differ. Global disability, many of the studies that have reported global disability used the modified ranking scale just for global disability, and you would know that the modified ranking scale might not actually tap the major concerns of a woman, a pregnant woman, or a postpartum woman who has suffered a stroke. Because if you look at the lower level of the MRS, it talks more about self-care, being able to care for yourself. But you know that, of course, a woman that has given birth to a baby, the care now is beyond just self-care. What about the baby? How is she able to take care of the baby, breastfeed the baby, bathe the baby? But unfortunately, the outcome measures used in many of the studies was just to assess global disability, all about the woman alone, nothing about the baby. Also, discharge destination, are they discharged to nursing home, are they discharged home, rehabilitation, inpatient rehabilitation, this has also been documented. Delivery outcome, was the delivery eventful, was it complicated, and all of that. Also, the form of delivery, was it SVD, spontaneous vaginal delivery, or did the woman require a cesarean section? Fetal outcomes, mortality, premature birth, fetal distress, all of these outcomes have been recorded in many studies. I did a sample literature search in PubMed to look at the pattern of outcomes reported in the studies available, some of these studies, using key term stroke in pregnancy, the search term stroke in pregnancy. And the focus was more on mortality as an outcome, followed by the discharge destination, followed by disability, and then the fetal outcome. And the reason for the somewhat lack of, not equal focus on disability is because many of those studies were not rehabilitation studies. They were incidence studies. They were retrospective studies that just looked at, okay, how many women had stroke in pregnancy and what was the outcome. So it was not really, those studies were not designed specifically to look at disability, which would have been the case if the studies were probably conducted by rehabilitation experts. So when you look at the outcome that I just presented, mortality, disability, fetal outcome, and compare it to this slide. This slide shows the outcomes that women, this is as a result of a study that was conducted to check what outcomes are women concerned about following pregnancy and delivery. This was a study, an international study by Nagal et al., and it involved all continents except South America. And the study involved focus group discussion, Delphi methods, just to arrive at the outcomes that should be assessed in pregnant women and in pregnant and postpartum women. And you can see that none of the major concerns of the women has been taken care of in the studies based on the last slide I showed. Mortality, just global disability, and all of that is not so much, of course, mortality will not be an issue in this case, but quality of life. The women, they would love to have their quality of life assessed based on this study. They would love to have their mental health assessed. They would love to have their incontinence assessed and addressed. Concerning their infants, how they can care for the infant to create bond, how to breastfeed confidently and successfully. And also, they would love to be asked how satisfied they are with care and their experience with delivery. This study was done among pregnant and postpartum women generally, not women that have suffered stroke. But it tells us, it gives an insight into what really matters. And when we talk about client-centered care, it should be about the client, it should be about their perspective, it should be about what they are interested in, it should be what concerns them. But we can see that has not been taken care of. Probably the rehabilitation professionals will be in a better situation to assess some of these factors that are more that the pregnant women and postpartum women are interested in, but unfortunately the data is not available. So we've gone through the available data, which clearly favor acute care, acute management, incidence, epidemiology, and general outcomes. But when it comes to rehabilitation, the data is really not there. So rehabilitation for stroke in pregnancy and the puerperium should be evidence-based, as we know, should be value-based. At least the outcome, the effort put in care should be justified by the outcome. It should be client-centered, it should be accessible. And using the ICF model, the International Classification of Functioning, Disability and Health, we know that many times when we are looking at the effect or the impact of our rehabilitation as physiotherapists and even occupational therapists, we can use the ICF framework to actually analyze the effect of our care, also to assess at baseline, and also for follow-up to see how well we have been able to achieve the goals, the collaborative goals set with the patient. So looking at body function structure, activity, participation, and quality of life. Of course, we also, in rehabilitation research, we look at discharge destination, we look at length of hospital stay, and similar service-related outcomes. But beyond that, the ICF provides us a good framework to look at our outcomes and to also assess our clients prior to our intervention. So these are the rehabilitation outcomes I am asking in this paper. That where is the data regarding how these outcomes, how we can access data on these outcomes when it comes to stroke in pregnancy. We know that the activity of a pregnant woman and a nursing mother will go beyond what we have in the Battle Index, will go beyond what we have in the MRS. The participation will go beyond what we have in our chart, what we have in our London Handicap Scale, because the pregnancy and postpartum experience is unique. It's quite a unique experience, an exciting time. And so many of the generic or even stroke-specific outcome measures that are used for general generally for stroke survivors might not really tap the very important constructs that affect the pregnant woman or the postpartum woman. And then quality of life. We know that when all is said and done, the ultimate goal of rehabilitation is to enhance quality of life, to ensure that our client is satisfied with life and is able to live as near normal as possible. So when we're talking about rehabilitation outcomes in stroke, in pregnant women and in the postpartum period, it is important that we are able to assess this and then address this with our interventions. That is expected. We expect that is what is going on in our clinics, in our health facilities, but the data is not there. We don't know what is being done, and we don't know what the outcome is. So I decided to do a PubMed search again, using the PICO format, only that I did not have the comparison. I did not input search term for the comparison. I just used the P, that's the population of the problem, and then the intervention to see what is out there regarding stroke in pregnancy, what has been done regarding rehabilitation, and then the outcomes are using the ICF, of course. I looked at motor function, motor performance, activities of daily living, participation, quality of life, to see if we have studies that have actually looked at this and what they found. These search terms were, of course, the Boolean function was used to combine some of the search terms to be able to find out what we have in PubMed. Many of my searches came out with 0 results. I have my computer screen filled with so many zero results. My NCBI page, so many 0 results, because the data is just not there. These 2 studies were some of the relevant search results returned. The first one was a study done in Malaysia, and why I believe this study was found in my search was that it's a case report, and the pregnant woman in question, whose case was reported, had undergone physical therapy prior to her going for this traditional Malay massage. The traditional Malay massage, based on the information in the study, has some spiritual components. It's a traditional thing in Malaysia. And so the patient in this case report had received physiotherapy, had gone through all the conventional treatment, and it was reported that her recovery was slow, and then she went for the traditional Malay thing, massage, and they reported the outcome. It is curious, or it is interesting to note that while we have so many evidence-based interventions that we use in stroke, case reports to show how such interventions were effective, or the outcome of such interventions for women that have suffered stroke in pregnancy and postpartum, when such case reports were not found. In fact, the journal for this study, the journal in which this study was published was actually a journal of complementary and alternative medicine. So it just further shows that there's a lot to be done in rehabilitation research to address this very important scarcity or dearth in information. Also, my search returned a retrospective study, and when I looked at the study, some of the keywords that probably made the PubMed search to return this particular study as a result was that it talked about discharge destination for women that have suffered stroke in pregnancy, and it looked at those that were discharged for inpatient rehabilitation, those that were discharged home, and that continued with community rehabilitation. That was the only reason I believe this study was returned in the search. There was nothing about physiotherapy intervention in it. There was nothing to show to indicate what intensity, what frequency, what modality was used. It was just the outcome in terms of discharge destination that made this study to be returned. A third study was returned, but it's rather a worrisome kind of report, and that report was on how it was a case report too, and it was on how a woman suffered stroke in pregnancy following cervical manipulation. That result was returned, but it doesn't fit into the topic, and it's even a negative. The topic, the study was titled "Stroke After Neck Manipulation in Postpartum Period." So that is not a positive outcome, and that's not what we are after. We're looking at how rehabilitation specialists can actually assist, help women that have suffered stroke in pregnancy to recover function, to go back to their life. And it's also important to mention at this point that many of the studies we do, some of the studies I've done, return to work after stroke, return to leisure after stroke, might not, when we're thinking of planning future studies that would address these deaths that I've shown, such studies of returning to function might not be applicable, because in some women, especially primary gravida, somebody that is just having a baby for the first time, it is not about returning now, because the experience is a new experience. So it will be more like a habilitation, kind of trying to teach how to do things that has never been done before. So that also is something that we should look at in moving forward and planning how to address the death that we have identified. So remember, my topic is on outcome and competencies. The competencies for the rehabilitation specialists to actually address the problems that would arise from stroke in pregnancy would require that such rehabilitation professionals will have advanced competencies. Core competencies, yes, collaboration, communication, practice skills, and all the rest, scholarship. Yes, those are core competencies in physical therapy. But beyond that, when we look at stroke in pregnancy, what will be required will be specialist skills, knowledge, and advanced attitudes, and even experience, which comes, of course, that would not be applicable for an entry to practice kind of situation. It would mean that the individual physiotherapist has been in practice. So without the data, what specific competencies are needed for effective stroke rehabilitation? And how do we arrive? How do we know these competencies? Of course, literature is replete with ways in which competency statements are arrived at. It will entail a very extensive literature search. It will entail focus groups. It will entail even having the clients and probably their caregivers to be involved, to let us know what their goals are, what really concerns them concerning our rehabilitation. So where's the data? What competencies should rehabilitation specialists involved in stroke care for pregnant women, what competencies should they possess? It might just be, yes, an individual believes he has the competence, but there's nothing documented. And that will affect training, that will affect accreditation, that would affect even assessment and even self-reflection to know if we are doing the right thing. So we need data on the specific competencies. Also, the rehabilitation needs. A lot of studies have been done all over the world about rehabilitation needs. But as has been the case, it's usually a global thing. Generally, stroke survivors, maybe young age group, or the older, or in some specific locations. But there is no study, there's no available study looking at the specific rehabilitation needs of survivors of pregnancy or Puerperium-Related stroke. We don't have that data. Then practice recommendations. The general practice recommendations we have for stroke, the one by Duncan PW, the one we have in Canada, the ones I've shown earlier, that those ones were on acute care, those were, and the other one on secondary prevention. But there is no practice recommendation or even consensus statement to let us know, to guide. And we know that if we have such guidelines available, it will help in knowing what competencies are required to be able to manage successfully this unique group of patients. And then what are the training needs of specialists involved in rehabilitation of survivors? We also need to have data regarding that, because a personal experience I had with a pregnant woman who had a stroke, that was during my master's years at the University of Ibadan. I was actually a bit scared because I was not prepared to address such a problem. The woman in question had stroke on the 8th day postpartum. In my country, the 8th day is the day we have what we call the naming ceremony, where we celebrate, call friends and families, we give the baby the names, and it's always a big deal. But this woman in question had her stroke on that very day. So the trauma to the husband, the trauma to the family was immense. And then as a young graduate who, was just in her master's program, when I was confronted with that case, I was scared. I was at a loss. I was careful with my choice of words. I knew the environment was tense. The woman was always crying. Everybody, the family members were there with her in the room, in her room at the hospital. Everybody was sad. So coming fresh and not knowing what to say how to communicate in a way that will not aggravate an already bad case or an already bad situation was quite concerning for me. And I can say that experience, that singular experience, was what even stimulated my interest in this area. As Dr. Barbara Shea read out when she was introducing me, this for me is a new new area of interest. My previous studies have been generally on stroke, more on participation, return to work, leisure, quality of life, generally. But over time, I've come to realize that this particular group, as women that have suffered stroke in pregnancy or postpartum, they appear to have been neglected. And many specialists, rehabilitation specialists, might be in my shoes, might be in the same situation I was in those years. And therefore, we really need to do something to get data available for this particular group. Sorry? So, that would require having competency statements, competency sets generated to help specialists in attending to the needs and to provide best possible care for this group. So what is needed at this time? When I started this presentation, I spoke about what we know now. There are many things we know now about stroke in pregnancy. We know about the incidence, we know about the pharmacologic care interventions, we know about the surgical intervention, we know about secondary prevention. And many of this data came from, or some of these data came from just case reports, case control studies, case series, many more from retrospective studies, just looking at the records, hospital records over a period of years. how were they managed, what was the outcome, and then from there, systematic reviews were done, meta-analysis were done. So we can start from case reports, case series, and it's interesting to know that many women that have suffered stroke in pregnancy even come out to tell their own stories. If you check the Heart and Stroke Canada, I found that organization. I found them to be at the forefront. I consider them to be at the forefront of getting so much awareness to a global audience, as it were, about the problem of stroke in women. They are doing a very good job, by my estimation. And on their website, you will find stories of women that have suffered stroke in pregnancy. They share their stories, their experience. There was one I read, 2 years on after the stroke, the woman was still having physiotherapy and occupational therapy 3 times a week. So it shows that we are caring for them, but we are not making the data available to help for helping out in creating guideline statements, competency statements, providing evidence for what works and what does not. So we can start with case studies, case reports, retrospective studies in a particular physiotherapy facility, maybe 20 years, how many stroke in pregnancy cases were managed, how was it managed, what was the outcome. That would help. That would be a first step. And then we build on it. Yes, everybody appreciates that RCTs, randomized control trials, might not really be easy to be conducted among pregnant women. In fact, many RCTs exclude pregnant women. Exclusion criterion, a major exclusion criterion for many RCTs for intervention, especially pharmacologic intervention, is pregnancy. They exclude them. But a case report, a case series, is just a natural history, and they followed up and documented, and then we can build on that. Cohort studies, retrospective or prospective, case control. Also, rehabilitation practice guidelines. But the problem here is that you can't have practice guidelines without literature, without data, because you must base your recommendations on evidence. So it still boils down to the issue of research. If we have data from research, then we can go to the next step of having practice guidelines or even consensus statements. Also, competency sets must be developed, and then outcome measures. As I said, the outcomes that are important to the pregnant woman might not just be tabbed by MRS. I mentioned the Heart and Stroke Foundation. They have the program Time to See Red. Also, the American Heart Foundation, Go Red for Women. All of these programs, initiatives are geared towards creating awareness about the problem of stroke in women and how that they are underserved, underrepresented in research, and something has to be done. So these are laudable initiatives in my estimation. Thank you.
Well, thank you very much, Grace. We really just have about time for one question, if anybody's got any sort of burning questions. We have the room booked after this. So does anyone have any? No. Yes. Come here. Sorry.
Thank you, Dr. Onabajo. I don't know if you are seeing me. This is Yinka.
Hello, Yinka.
Yeah, she was my lecturer in school, back in the school. I don't know. Can you see me?
Yes, I can. Hi.
Hi. I was so happy when, when I saw that you'll be presenting today. I actually thought you were going to be here. So I had to rush down to, so I never knew it's going to be through Skype. So I'm happy to see you. I'm here right in Canada. I'm doing my PhD. My advisor happens to be here too, Dr. Ruth.
Proud of you.
Yeah, thank you so much for your presentation. Even though I came later, but I had you've been speaking about the scarcity of data on this particular area of research, and one thing that just struck my mind was that do you think that this could actually, this scarcity or paucity of data on this area of research could actually be due to, the recorded prevalence or incidence of stroke postpartum in women? Do you think is actually related to that because of maybe the low prevalence we probably could have here in Canada, but in Nigeria, I think we could have more incidents. Thank you.
Yeah. Thank you. Shall I go ahead?
Yes, please go ahead.
Yes, thank you, Inka. I stated that at the beginning of this presentation that stroke in pregnancy and the postpartum period is regarded as a rare event, but the incidence is increasing. And then beyond that, I have been able to show that other studies regarding other kind of interventions, pharmacologic interventions, surgical interventions, they are available. Where the missing link is, where the dearth is with rehabilitation research. So yes, it is rare, but that should not be enough justification for scarcity of data. So I believe more can be done, and we can start even with little steps, case reports, build up on that. But this is an important group of people. We cannot afford to neglect them. Thank you.
Thank you very much, Grace, and appreciate your time today, and I'll be in touch with you after today's presentation.
Thank you.
Bye.
Bye. Thank you for the invite.